Hello guys, hope you're all okay. You're all enjoying your life and you're also enjoying watching my videos. I'm Dr. Arshad Nadeem Awan with my ultrasound videos. Today I'm going to discuss particularly about the focal endometrial thickening. In the previous videos, I have discussed at length about the generalized endometrial thickening, but today we are going to look for the focal endometrial bulge or focal endometrial thickening. This could have been possible because of the endometrial polyp. It may be possible because of endometrial hyperplasia, focal endometrial hyperplasia, or it may likely be due to hyperplastic polyp, especially in 30 to 60 years of life. Hyperplastic polyp can be seen in those who are already on tamoxifen, and on the ultrasonography you may be able to see a small echogenic pedunculated mass. You may be able to see small stack on the ultrasound or Doppler imaging. This could have been due to primary carcinoma of the endometrium, especially when the endometrial carcinoma is in the fundal area or around the fundus. So in response to that endometrial carcinoma, you may be having this focal bulge or focal enlargement of the endometrium up to 18.2 millimeter. So that is the another criteria. So you should have to measure all the time and you should have to look for the endometrial thickening. It may be because of the metastatic deposits from the ovary or from the fallopian tube or from the cervical area, and even in the leukemia there may be metastatic deposit. This could have been possible because of the hydatid form mole, or there may be incomplete abortion, or there may be focal adenomyosis. How it will appear on the ultrasound imaging, how we will differentiate all these one point from the another point. You should be very much careful while you are scanning the patient, especially on transabdominal or transvaginal. You must pay focus and pay attention to endometrial thickening, and if there is any irregularity around, or if there is any bulge within it, you must pay attention and raise your concern. So this video will explain all these points. So let's start watching these images. This is a clear view of the transvaginal scan, and you can appreciate that the endometrial is thick. Myometrium is quite normal, endometrial thickening is there. You know that the endometrial thickening vary according to the phases there. If there is a proliferative phase, so this should be up to in between 5 to 10 mm, and if it is secretory phase, so it will still proliferate because it is also proliferating due to the glandular activity, and if it is menstrual phase, so it's likely to shed around that time. As far as this endometrium is concerned, if you pay attention to its echogenicity is not uniform. It is showing small cystic degenerative changes within it, so you have to give the differential over here. It may likely be due to hyperplastic changes, so this may be a generalized hyperplasia. So you have to be very careful when you are doing or you are seeing these small cystic areas within the endometrium. This is another clear view of the transvaginal scan. The uterus is anteverted, but here in this scan you can see a generalized thickening of the endometrium with a homogeneous echogenicity. So there is no focal bulge, it is uniformly enlarged, and in that case it could have been due to hyperplastic changes. So this may be a generalized hyperplasia. Beside this, there may another possibility is likely that if there is any carcinoma developing around, so you may be able to see some changes within the myometrium. If there is another abnormality within the myometrium, you may think of that this might be because of some carcinomatous response. As far as the metastatic deposit is concerned, still in that case you may think of metastatic deposit from the ovaries, from the fallopian tube, and from the cervical region. So far polyposis is concerned, it is not likely because the homogeneity is quite uniform, so the polyp presentation may not be likely. As far as incomplete abortion is concerned, still you can't consider that, because in case of incomplete abortion there may likely be some other changes associated with Well, the third and the fourth differential may be a adenomyosis changes. For that matter, you have to look for the endometrial changes as well. Beside the endometrial changes, you have to look for the myometrium changes. If there is some changes within the myometrium, you may consider the adenomyosis in your differential. Now this is the case for the true discussion. Here you can see this endometrium is highly proliferated. Beside this, there is a nodular formation and the focal bulging as well. So a variety of differential you should have to keep in your consideration, but if there is clinical history available, you may narrow down your differential. For example, the first and the topmost may be endometrial polyp, and the second will maybe a hyperplastic polyposis. So these two could be on the top, and if the patient having any history or candidate for the carcinoma, so you can still think of that, and for that you need to have the FNAC or curate or biopsy, so to confirm these things. In case of metastasis, there may be the history of ovarian or fallopian tube or the cervical carcinoma. So far the incomplete abortion is concerned, you still consider that because of the heterogeneous appearance of the endometrium. Focal adenomyosis is the another topmost differential in that case. So these all presentation is depend upon the history. If you have the relevant information and the relevant history with you, keeping that history, you can narrow down your differential, and you can clearly mention on your report the possible 2 or 3 differential, which will help the gynecologist or clinician to work upon. This is another transvaginal scan, and in that case I would myself suggest that this type of endometrium with the hyperplastic changes. Whenever there is hyperplasia of the endometrium, a focal part will show the cystic degenerative changes or maybe cystic changes because of any glandular activity. So hyperplasia may likely be so in my case, and I would argue for the endometrial hyperplasia in that case, regardless of any other differentials like carcinoma or metastasis or hydatidiform mole would be my second differential in that case. But I won't go for the incomplete abortion, and I won't go for the focal adenomyosis. Well, I would not be very happy with this scan because of the fact like this gives rise to, or this start ringing bells because of the certain differentials in my mind here. In that case, because of the vascularity to the endometrium, and particularly endometrial focal bulge which is protruding into the cavity surrounded by a small fluid within it, it may give rise to the suspicions of the endometrial carcinoma on the top. In the second differential, I would consider as a secondary to the any endometrial carcinoma, or maybe secondary to ovarian or fallopian tube or cervical carcinoma. This would be the top second differential of mine. Endometrial polyp, but this would be a bit hematomatous type of endometrial polyposis. It would not be an hyperplastic polyposis. I would not consider that. And those who are on the tamoxifen, you may consider this differential. So for the hydatidiform mole is concerned, it is very unlikely, and in case of incomplete abortion, if the history of abortion is there, so you may still think of that. As far as focal adenomyosis is concerned, this would be the last differential of mine I will put on my report. On this particular transvaginal slide, I would not be very happy with the endometrium, as this is a focal enlargement or proliferation of the endometrium with cystic degenerative changes within it, making it suitable for the consideration of the primary carcinoma of the endometrium. And beside this, in the differential, you may think of hyperplastic polyposis or development of the hyperplastic polyps. And at the third differential, I would consider it as an focal adenomyosis. This is transvaginal scan, and on it you can see the thickened endometrium. However, it is generalized thickened endometrium associated with central cystic degenerative changes, making it suitable for the diagnosis of endometrial hyperplasia, or maybe development of the hyperplastic polyps, because of the fact that the patient is on the tamoxifen. So tamoxifen making it some like there will be a cystic degenerative changes if someone is taking tamoxifen associated with the cystic hyperplastic changes of the endometrium. So this may be hyperplastic polyposis or endometrial hyperplasia. This transvaginal scan and the image is slightly fishy because of the fact like the posterior wall and the penetration of the endometrium within the myometrium shows that this some pathological process is going on. So on my first differential I would go for the endometrial carcinoma, and in the second I will include the metastatic deposits from either the ovary or fallopian tube, and I will look for the history. And in the third I would look for the hyperplastic polyposis changes, and this is also making it suitable for the focal adenomyosis changes. So generalized endometrial thickening and focal endometrial thickening discussed side by side with the possibility of having endometrial hyperplasia or endometrial polyposis or hyperplastic posis. Beside this, I discussed about the primary carcinoma, and I've shown you the slides where you can think of primary CA and metastatic deposits as well. Focal adenomyosis was also on the list. You may think of incomplete abortion in case of available history of the previous pregnancy positive test, and also hydatid form mole as well. So hopefully that you will benefit from this video. You will share this with other colleagues as well, and you will put all these information into your clinical practice. With some other informative video, we'll see you each other. Till then, that take great care of yourself. Thank you.